Hello everyone and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at PwC. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Afterwards, stay on for an exciting dog show performance with one of the leading dog shows in the entire Midwest. And with that, I will throw it over to our moderator who joins us from PwC, Ben Isger.
Well, thank you, and it's great to be here with everyone today. We have a lot to talk about, a lot of interesting things going on out there. Kind of the basis for the discussion is around a report we just released called Behind Numbers 2021. Is our report about medical cost trend, and this is an annual report, or in fact our 15th year that we do at PwC's Health Research Institute, which I lead. And I'm really happy today that we've got a great panel, because this will not just be a readout of the report itself. It's freely available on our website, but really a dig into some of the issues that our health system is going to be facing in 2021 when it comes to costs, employers and other payers that are paying for our health system in 2021. And to help me do that today, I've got a great panel joining me. And we'll go through an introduction for each of them. Well, they'll each have a chance to tell you about their activities and what they do in the health ecosystem. So first up, we have joining us Serena Fong. She's Staff Vice President of Strategic Initiatives at CareMore and Aspire Health. Welcome, Serena. Serena, I don't know if we have you.
Thank you. Hi, yep. Ben.
Hello.
And hello, everyone. Good afternoon and good morning. As Ben said, I'm just so happy to be with everyone at CareMore and Aspire Health. I really look at planning in terms of what's coming up next year and executing on our major initiatives. And CareMore and Aspire Health, we're an integrated care delivery system, really caring for high-risk, underserved populations with complex needs. We really we have such a passion for our patients across our 34 states and DC, and we have over 50 clinics. So we do in-person and actually residential, and so we're just so excited to be here.
Great, thanks, Serena. Also joining us, we have Chris Wasden. He's the head of Happify Digital Therapeutics at Happify Health. Welcome, Chris.
Hello, thanks, Ben. Yeah, at Happify Health, we focus on digital therapies that are used for patients who are suffering from stress, anxiety, depression as kind of a or primary condition. And then we look at other conditions that we can provide some benefit in. One of our areas of focus right now is MS, because they suffer from not only anxiety and depression, but also fatigue and other related symptoms. So we start from that mental health base and then expand from that into other disease areas and other symptoms that we can address within those diseases.
Super, thanks for joining us. And we also have Mike Thompson, President and CEO at the National Alliance for Healthcare Purchaser Coalitions. Welcome, Mike.
Thanks, Ben. And, at the National Alliance, we're the umbrella organization for employer coalitions across the country. We have 45 coalitions, represent 60% of the Fortune 100, a lot of mid-sized employers, typically self-insured, includes the private sector, but also the public sector, states, cities, school districts, federal government, federal employees, for example, as well as union groups like UAW or 32BJ. So it's a very broad group, collectively represents about 45 million. And you can imagine this environment has been incredibly impactful, disruptive, important in the context of employers in every element of their business, not just healthcare.
Well, thank you, Mike. And it's great to have everyone. I think we're going to have a great conversation with a lot of diverse viewpoints in terms of the health ecosystem. Well, let's start just with a little bit of framing. And the way that this is going to work is each section will show just a bit of data from our report to kind of frame up that section, and then we'll move right into panel discussion. And we'll do that throughout, leaving, of course, 15 minutes at the end for questions, which can be typed in the question box. So that's the part we all look forward to, is finding out what's on your mind. So on the next slide, I think we have kind of the genesis if you will, of this research, which is around medical cost trends. So that is what the inflation rate of medical costs. So what are employers going to be spending next year in comparison to this year? Now, most years, it's not very straightforward even doing it most years. Of course, in the year of a pandemic and COVID, with much of our health system sometimes almost completely shut down over some of the past months, some of it opened back up, shut down again, this becomes quite difficult because utilization can be very low and then spike up again. And so there's a lot of variables there. So for the first time ever in the 15-year history of our medical cost trend report, we actually did not come out with a single number in terms of that growth rate between 2020 and 2021 for the employer health spend. We came up with 3 different scenarios. And the reason we came up with scenarios is because of the number of variables. So the variables can be the geography, where are your businesses, where's your company located, and what's happening with the pandemic in that area. Variables can be the type of company that you are, and whether your employees can work remotely or not. It might affect ultimately rates of COVID and things of that nature. So a lot of different variables out there this year, and we felt like the scenarios were one way to kind of approach that range of anywhere from a 4% growth rate, which would be a bit lower than we've seen in the past few years, all the way up to a 10% growth rate, which would be substantially higher than we've seen in the last few years. So with that in mind is kind of the framing, this uncertainty and what exactly are employers going to do when it comes to trying to price their benefits plan in 2021. Mike, I'm going to start you out with the hard question, which is, how are employers thinking about this, and how might benefit designs change in the next year?
Well, first of all, we talk about 15 years of behind the numbers. I feel like I lived every one of them. So this is we've never had a year like this in the history of behind the numbers. I know that to be the case. And even defining what trend is, that's never been an easy thing to define in a normal year. But this year, you're usually talking about a base year of claims and how much will it go up next year for the next year's claims. Well, what base year? What months are included, and where are you located, and where was the virus then, and how did that impact all the other care? We know that we're in a very low period of utilization, in spite of very high use of emergency rooms and ICUs for COVID virus in some parts of the country. Overall, because of the drop in going to the doctor, going to the emergency room, elective surgeries, all that, the bottom has fallen out on healthcare costs. And so when you're talking about, quote, trend, are you coming off an artificial period or not? Or is this a new normal? Are we going to live like we have for a while into next year and maybe forever? Are we temporarily adjusting, or are we permanently adjusting? And the answer is going to be somewhere in the middle. And so the idea that you can pin a number is not that, short term, I think employers are, like health plans, there's not a concern about healthcare trend costs are down. Long term, what happens when people defer care? What happens when people don't get preventive services? What happens when people aren't immunized? What happens when the mental health epidemic compounds the impact on chronic disease? Who the heck knows how big this could be next year? And so employers, I think, frankly, are not in the position to have a perfect crystal ball. A lot of people want to trend from last year when it was kind of, quote, normal. But I don't think employers want to do that either, because I don't think we want to go to that system either. I think we want to look at what have we learned in this period that we can capture the gains in, fix the things that aren't happening. How do we improve high value care? But let's not bring back that low value care. And then how do we adjust to a new environment? And I know we're going to talk more about that going forward. How much plan design change will happen next year? Probably not all that much. And the reason, employers have been terribly distracted by trying to get back to business. I mean, trying trying to get people, back into the workplace, managing through this COVID thing. All the strategic planning that normally would happen around this time of the year has been put on hold. You're not seeing as much movement. I do think that during 2021, and certainly by the end of that year, we could have radical changes in employer strategies coming out of this. But I don't think we're going to be looking at it at 1/1.
Yeah, and I think that's an interesting point to make of maybe another year of holding steady and then thinking about potential radical changes and benefit designs in some of the future years. But I'd like to bring Serena you in on this as well from a provider perspective. A lot of what Mike was talking about comes down to value and employers trying to figure out how they're going to price plans, what the benefits are going to look like. But ultimately value and what providers can help them with. So any comment on what you're seeing?
Yeah, I think, throughout this time, what's been really painfully clear is those times in between care and some of the benefits, for example, that we're making sure we act on are things that relate to social determinants like meal benefits. And from a transportation standpoint, that was the case. That was a very big part of our benefits. Right now it's tampered down, but like the meals during COVID, we actually got, an emergency benefit set that whoever even had food insecurities, we were able to deliver that. And that really shows that the focus on social determinants and making sure that we understand those life situations, if there's a benefit there, we actually act upon it as a provider to make sure that we do that, understand that, and deliver it to our patients.
And Chris, anything you want to add on this kind of value equation and price and cost going forward?
Yeah, I think there's some key issues that we've learned through COVID. Number one, and this is not a surprise, we find this all the time, consumers are much more willing to be innovative in care delivery than our clinicians, right? So consumers, as soon as we provided telemedicine, you saw them flock towards that as a solution with significant triple-digit increases in the amount of telemedicine provided by providers out there generally. So I think consumers are very much eager to have this new delivery of care. I saw a recent study, though, that said that since we began opening the economies in different parts of the country, the number of telemedicine encounters has decreased substantially. And the reason for that is that payers are not paying for telemedicine in a way that it's enabled to be sustainable. So what we've learned from COVID is that telemedicine is an effective way to deliver care and that consumers, patients will adopt it and use it. But we still have to pay clinicians for delivering this type of care if we want it to be sustainable in the future.
Yeah. Well, let's start playing off of that a little bit, and we'll move away from the high level view of overall costs, and let's move into what our portion of the research that we call behind the numbers, right? Which are the inflators, the potential inflators and deflators of trend for the coming year. And here's one that I'm going to describe just with a little bit of nuance here. And that is sometimes an inflator of trend can actually be a good thing in the long term. And so if you look on our next slide here, we're looking at mental health utilization. And what our research showed, and Chris, you alluded to this with Tella and others, a big increase in mental health utilization. In fact, a survey that we conducted in early May, about 30% of consumers that have employer-based insurance plans said they sought help for their mental health as a result of the pandemic. And this also connects exactly to what Serena was talking about with the social determinants of health. Our consumer surveys around social determinants pre-COVID and during COVID showed an increase in issues around loneliness, use of technology, lack of ability to exercise and diet. So we do think there's going to be a higher utilization of mental health services in 2021, but that's not necessarily a bad thing because there could be a lot of long-term savings and positive outcomes because of that. So I think let's start with you, Chris, on this. I mean, you're sitting front and center in the mental health arena, and in fact, I'd like you to maybe address how can we as a system address some of the gaps that we're seeing between the need and the ability to get help.
Sure. So the first issue we need to address is the fact that we've ignored mental health as a country and as a health system for a long time. Part of it is because mental health is very difficult to diagnose and treat compared to some other conditions that we deal with. The good news is the last 2 or 3 years, we've seen mental health emerge among employers as the #1 issue that they want to address with their employees. And so that's been a very good acknowledgement on the part of employers that this is a priority that needs to be addressed not only in the workplace, but also in the health system and in the health plans that are offered to their employees. So with that recognition, we then have to move towards execution. And the problem that we have around execution for mental health is that we have all these acknowledged shortages in clinicians that treat and diagnose mental health. We have shortages in therapists that treat it as well. And so just trying to address the shortage issue requires innovations that go beyond what we've traditionally done. Some of the innovations that you've seen emerge with a number of different companies have to do with telemedicine or telehealth consultations. That's nice. It creates greater convenience. It saves some money, but it doesn't address the fundamental shortage we have in healthcare professionals that can help these patients. And this is where technology in novel ways has to come into play and really address it in ways that would enable patients to do more self-treatment and self-management of their condition. And that's where a company like Happify Health steps in and says, we have technology solutions that are based upon the best science out there on how to provide interventions that enable patients to manage their mental health conditions and in some cases treat those conditions. And we can deliver these to people in very engaging, small bite-sized chunks that they're able to consume over the course of a week that would be as effective or more effective in many cases than an in-person encounter with a therapist or with a clinician. And so what that means is that by using technology now, we can actually start to address this shortage of human talent that we have that is necessary to diagnose and treat these patients.
Yeah, and I think, Mike, maybe just to bring you in on this, from the employer perspective, our HRI research showed that someone with a mental health condition and a complex chronic plus mental health is going to cost about 12 times more per year than your quote healthy employee. So, what are employers doing to get active in this area?
Well, reinforcing what Chris said, employers we're already active in this area, and you said, before, Ben, investing in mental health does not necessarily cost you money. It can save you money.
Yeah.
If you invest more in mental health, you will spend less on other conditions, and we know that a high percentage of people that have mental health needs don't get any support, or they get very minimal support, or the support they get is not professionally delivered. It might be through primary care, and it might be throw them a pill and see what happens. And there's not much that's going on there. I want to correct one thing here, though. What's going to happen this year is not the product of employers promoting mental health, which they have been with their workforce. That has been the product of the last few years. What's happening right now is an epidemic of mental health issues. We already can see from February to May, and these surveys get outdated in 3 weeks. So remember, this is current data, and we'll be reporting new data in a couple of weeks, or actually next week for June. But through May, the risk of depression had gone up by 160%. 160%. So now the good news is mental health has never been a big spend. The bad news is when people are not at their best, everything costs more. Not mental health, everything costs more. And worse than that, we're going to lose lives to this. This is going to be every bit as important, as critical as the COVID virus itself. This is just as big, maybe bigger. And what's causing that? It's the isolation of working at home. It's the fear of the virus. It's the racial tensions. It is all of the above, the economic distress. All of those things have come together at the same time, and we're just seeing it across the population, and some subpopulations even more. And so you can't imagine how important mental health is than it is this year. And I'll say two things. One is we need to flatten the curve, and this is what I think employers are looking at. How do we help our employees to better manage, be more resilient, engage in this, don't lose their social connectivity and all that. And that's very important work. And I think every employer is taking that as job one right now as it relates to mental health. But the other part is part of what Chris alluded to before, which is this was a system in crisis before the pandemic. This was a system where people could not get care through their networks. This is a system where they go to their primary care physician and they either get ignored even when they bring it up, or they get treated without true professional help. And so what the National Alliance is promoting is the path forward for mental health and substance use. We've been promoting it and we're doubling down. It speaks to improving network access. Yes, the technology solutions, the telebehavioral health, but also integrating behavioral health into primary care. We have to have primary care, and we need to get more professional. We need to have measurement-based care, which means that we need to be screening regularly. And secondly, when we are providing care, we're taking a baseline and remeasuring, because if you're just throwing a drug at it and hoping it works, we know that doesn't work in mental health, and the outcomes are improved 20 to 60% if you take a professional approach to mental health. So this is a topic unto itself. I could talk all day.
Well, no,
Yeah,
it's an important topic. Go ahead, Serena.
Yeah, I was going to say, Mike, I mean, I know we, we have a history in terms of just sharing. I know you're passionate around mental health, and nothing really replaces that human touch. And, for us, behavioral and the social part, because we're not even seeing our providers, if you ever relied on that connection point, the community health workers that used to be out there in the communities, and they're not going out there anymore, they are now going on telephonic support. We have about 40 community health workers, and, they build that trust in the community to give us then a permission to play, to even get to a therapy. So that kind of trust element, and other people in the health system are really helping to bridge the gap. And, on social isolation, our togetherness program, which is essentially a phone pal program, where you adopt a senior. I have one myself. She's in Colorado. She's 74, and I call her every week. That is almost a both CareMore and Inspire taking up employer play in terms of we are the volunteers who actually connect with our patients, and then the patients actually get a social call every single week. So we are keeping in tune, and if we see anything that they need, then we refer them out to our community health workers, our clinicians, et cetera. But by being there, we've actually seen, it's been like, there was 100 referrals in the beginning of the year, and now there's nearly 1,000 in March and April. And so people have really really connected with that togetherness program.
And I would add something to Serena's point about this social connection. So an important part of our therapy approach is the social connection. And so what we do is we connect other patients with other patients so that they can provide support to one another. And this is really important from a social isolation perspective, but also in helping patients learn from one another what are the things that they've done in their lives that have improved their mental health. We also recently launched this last week a new platform called COPA, which is our care delivery platform that not only brings patients together to support one another, but also brings expert clinicians into the community discussions as well. And then we can have people organize also as dyads or as small groups, as well as a larger community, because having people be able to find mentors and to be able to mentor other people. In fact, from a mental health perspective, you get more mental health benefit from helping somebody else than you do from being helped. And so when we actually connect through our digital means, people together, that are helping one another, this actually improves their mental health.
Well, I think there's a lot to unpack here for employers, whether it's technology, whether it's social determinants, whether it's high touch and bring it all together for their employees. The pandemic has accelerated that need very, very clearly. I hate to do this, but I do want us to keep moving to some of our other issues. And we do have our second inflator for 2021 is around specialty drugs. And you can see some stats here from our report. But just in a nutshell, what is different than we've seen in the past? So we think about the total retail drug spend, about 21% of that was specialty drug back in 2010. 7 years later, that more than doubled to 58%. So that just means the proportion of drug spend on specialty drugs is increasing substantially. It's a top concern for employers. For our employer survey, 95% of employers ranked it as a top 5 pharmacy concern in 2020. And we expect that over half of the drugs that will be released this year and in 2021 will be specialty drugs. The issue is some of these drugs actually have very expensive price tags, 6 or even 7-figure price tags when you get into things like gene and cell therapy. So Mike, maybe you could kick us off with from the employer point of view. How do you manage what can be some amazing treatments for people, but also have some potentially amazing costs?
Yeah, and I'm glad you started with amazing treatments. I don't think we should not acknowledge that this is truly innovation. This is not Me Too drugs coming out. These drugs actually help people in their health and in their lives and whatnot, and acknowledge that. It's the prices, stupid, right? I mean, the prices are so damn high that I think employers are very, very concerned, collectively and even individually. I mean, you talk about drugs costing, $100,000, $1 million, multiple millions of dollars. Even an employer has a hard time absorbing that, especially a mid-sized employer. And when you put that in the context of their business, they hire somebody in their family has a condition, and suddenly they have $1 million drug that they're paying. And you say, well, buy stop loss. Well, the stop loss doesn't work. The stop loss will laser out that person the second year, and it's that employer's cost. It can put an employer under. We have to get back to rethinking what are we doing with our pricing. And frankly, pricing starts with being fair internationally. Why are we paying so much more than other countries? And then I think we have to look at our intermediaries. And frankly, a lot of these specialty drugs, most of these specialty drugs are coming through the plans, not the PBMs. And the plans themselves are not managing this with the same transparency as even the PBMs, which aren't known for transparency. And nor are we seeing the same level of diligence. So when you talk about the emerging issue of 2020, this is one of them. We are focusing on high amount claimants, and historically we would never put drugs in the high amount claimant category. High amount claimants, this is number 1 on the list, and we are going to be doubling down on scrutinizing the appropriateness and frankly looking at these middlemen markups that are really driving costs crazy, not just. And again, there's no accountability and no transparency. There's a lot of work to be done here.
So Mike, if you're an employer, listening right now, and you just had to pick maybe one thing for them to start doing, tactically to start tackling this, what's something that maybe is being overlooked that they should focus on?
Well, honestly, what we're starting with and what we hear from the employers is they don't even know what's happening. They don't know how it's being managed by their intermediaries. Again, and their intermediaries in this case are more the health plans than it are the PBMs. And again, they've always had concerns about the transparency of the PBMs, but every time we bring this up, they said, we don't even know what's going on. And when we open it up, we're not as convinced that our intermediaries have our backs on this. And we have to get aligned and get working on this issue. And appropriateness, I think, is maybe the low-hanging fruit. How many of these drugs are being offered in a way that we don't. Site of care is another tactic that obviously a lot of people are focused on. If these are being administered by an institution. They cost twice as much as if they're outpatient and then more. So there's a lot of micro strategies, but it collectively, it's a big issue.
Yeah. Well, let me open it up and just see, Serena, either you or Chris have any comments on the specialty drug issue?
Yeah, I can mention what we're doing in that area. So MS is oftentimes considered to be in this category of rare disease, especially drugs, because the size of the population is small. When you look at the MS drugs that are out there, which are all very expensive, they're dealing primarily or almost exclusively really with the relapse and remission of the symptoms of MS. But when you ask an MS patient, what are the things that really determine your quality of life on a day-to-day basis? There's really 6 things that come up: anxiety, depression, cognitive function, fatigue, motor function, and mobility. Those are the 6 things that really consume their waking hours day to day, because the relapses tend to happen every year, every other year, right? They're not really a day-to-day issue. So the drugs that we have for MS patients are not addressing the day-to-day issues of the patients that are suffering from this disease. So this is where a digital therapeutic company comes in and says, oh, those 6 things, we definitely can impact those 6 things. We provide therapies that are demonstrated to be effective in anxiety and depression. We have demonstrated also our ability to address fatigue with digital therapies. We can also provide interventions that deal with physical activity and diet and sleep, which deals with motor function and mobility. So we can be a complement to these medications that really change the patient's experience and their quality of life in a significant way and at a significantly lower cost than traditional drugs.
Well, let's go ahead and turn our attention to the other side of the house, if you will, to
Can I add one other point?
Oh yeah, go ahead, Mike. Yep.
One thing I just wanted to add there, because I felt a little bit bad. Hard for me to feel bad, but I did. I don't think employers are trying to get in the way of people with serious medical conditions and what they need to take care of themselves. And what we are finding as kind of an emerging trend, we're doing this, for example, with the National Hemophilia Foundation, is to work collaboratively with those patient advocates to get rid of the waste, to really focus on what do the patients need and who are getting in the way of the value that so that we can get the right care to the right people at the right time, but not waste money and allow undue markups in the process. So we are working together with patient advocates to get this right, and employers want that. They are not looking to get in the way of what people need.
Yeah, I'm glad you brought that up, Mike, because I think, our research around behind the numbers each year, there's an interest in what's the system going to cost in the coming year. But I think one of the most valuable pieces is that the industry gets to hear the employer point of view, right? The ultimate customer. And I think in some ways, this research does some of that. It bridges the gap and starts these conversations going. So I'm really glad that you brought that up. I did want to turn us to our deflators, and we do have 2 deflators this year of trend, and one of those is around telehealth, which has already been mentioned because it's just such an important part of the health system, especially during the pandemic. We've seen so much more use. I'm sure you all have seen some of these numbers, but our own PwC consumer survey showed that about 5% of the U.S. population used telehealth for the very first time during the pandemic. And if you break that down to the employer-sponsored insurance, about 6% of the total U.S. population with ESI used it for the very first time. Those are staggering numbers because that translates to more than 17 million Americans have used telehealth for the very first time. So with that in mind, we look at our research, we see it, again, continuing to be used at levels that we have not seen in the past. Serena, I'd like to bring you in here from a provider perspective. How are providers embracing this kind of new world of virtual care that has just taken off like a rocket ship over the last few months?
Yeah, and Chris, you and I have been probably working on this for many years. I remember, I think we wrote our first paper together on mobile health like at least a decade ago, and you cannot now open any news article that doesn't say a provider has pivoted so fast to virtual almost overnight. I mean, for all of us, we had to with the stay-at-home orders. And so overall, virtual care, while it's been a part of the strategy, it's been either a little bit like lurking in parallel, et cetera, but now it is gangbusters going on as a core part of the clinical model. And it's coming to the forefront, absolutely. And, you know, from PwC studies in the past to Harris polls recently, J.D. Powers, when you look at willingness and actual use of virtual health overall, there is actually a big gap. There's I think always been a willingness and an interest, but the actual use has been like under 10% pre-COVID. And so I think we have to ask ourselves, as we move into this new world, how do we make sure that we understand the journey of the patient post-pandemic, and how does it connect with the care models we give anyways? So at CareMore, we're launching like a virtual high-risk disease management model. And when we look at virtual care overall, it's making sure we look at analytics to actually identify high-risk CHF, diabetes, COPD patients, and then how do you actually then bring them together with a virtual care manager? Because don't assume that like they are ready and aware. You really have to guide patients through a process. And so as we do that and launch for chronic care illnesses, high-risk patients, that's a key component. And when you think about in-person care, you know, the whole, everyone's afraid to touch anything now. So contactless experiences that we are in retail, even think about as we're going back to the in-person care setting, like the flow before that, checking in, for example. So you got to think kind of not only at the visit, but all the stuff that surrounds it and how digital health is going to combine overall. So it's here to stay, Ben. It's a core part of our model. We are triple downing on how we can make it effective. And even on the kind of social side, you know, for togetherness, we are piloting our kind of social groups. So the nice seniors who used to go to the care centers and do flower arranging or other stuff together, now they're going online. We're sending them like bingo cards or playing games with them, and they're pretty darn excited to start connecting as they could.
No, that's a great way to, I think, put it. You know, it's here to stay, and also I think you brought up a really important point, which is it's not just the younger demographic that's interested in virtual care. Mike, any comments on, you know, how employers are viewing telehealth? I mean, they've offered it for years. Many have not had a lot of utilization. That seems to have changed.
No, it's amazing how quickly this has exploded, and and you know, I don't think we're ever going to put this genie back in the bottle. I think it's going to change. I think Chris had a great point earlier. You know, we really have to decide what we want, right? How do we want care to be delivered long term? There are some concerns about telehealth and the explosion. One is the loss of integration with the primary care physician and having kind of multiple systems. But frankly, we're seeing telehealth not be so much as a carve-out strategy as an integrated strategy going forward. And I think we need to figure out how to pay fairly for multiple ways to provide care. And, you know, frankly, I wonder, why do we over-incent people to go to an office when it can be done virtually? It makes no sense. You know, I got to drive to the office, I got to spend an hour in the waiting room, and then I have to spend 15 minutes before the doctor actually sees me. And I'm like, where's the productivity in all that? So I think this is going to be one of the hottest issues from a policy standpoint in the next 6 months. Talking about the gains that have come out of COVID, how should those be modified and codified going forward for the new normal, where telehealth and virtual health and the other interesting part of this discussion has been there is actually an economic disparity issue that is emerging because of some of the approaches to telehealth, where we've insisted, for example, on video, and it turns out big subsets of our population are not capable of getting video. And we are going to increasingly be thinking about things like phone and other interventions. And how do you balance that with kind of fly-by-night, the doctor calls and gets a big paycheck? We got to figure that out. I think this is going to be a thoughtful dialogue over the next 6 months and probably the next several years. But I don't think this genie's back in the bottle.
Yeah.
Yeah.
And Chris, what other parts of telehealth do you think we need to figure out over the next year? Just connecting to that.
So, Serena mentioned that in 2010, we launched Healthcare Unwired, which was our first PwC thought leadership piece around how digital was going to disrupt healthcare. And one of the things that we identified at that time, which was very challenging, is that physicians have never been trained, nor do they know how to practice digital medicine, right? So if I'm a physician, do I do my telemedicine consultations in the morning, in the afternoon? Do I do them interspersed between other visits that I have? And then what are my financial incentives? Do I prefer one versus the other? And Mayo Clinic did a study using telemedicine with primary care doctors. And what they found in a study of over a year's worth of providing this as a service option to patients is that over 50% of all primary care activity today could be done virtually with no loss in quality of outcomes to the patient and with substantial decrease in costs. So if that's the evidence that we have, okay, then why don't we incentivize the system to deliver that type of care? I worked at, prior to Happify, I worked for 5 years at the University of Utah with their health system. And I worked with a woman there that focused on how to cut in half all of the visits that a woman has during her 9 months of maternity before the baby's born. And what she found is that by cutting those visits in half, she had no increase in risk to the mother or the baby. She had substantial increase in the patient satisfaction by doing that. She decreased the costs to the health system by doing it that way. She provided remote patient monitoring to the mothers. And so rather than having a nurse take the blood pressure and weight and things like that, the woman could do it at home on those visits that were done telephonically. And so she demonstrated that this is a better form of care, but yet trying to get adoption among OBGYNs to do this has been almost impossible, even though she's demonstrated through studies with hundreds of patients that it's better care at lower cost. So we need to take this evidence from Mayo Clinic, University of Utah, and then say, all right, if this is the evidence, how do we provide the right incentives and the right support to move the system in that direction? Now, COVID has, I think, enabled us to do 10 years of progress in 3 or 4 months. But we have to sustain those gains. We can't let the system revert back to the way it was. And this is the concern that I had in this recent article I mentioned earlier, that it's showing that once we kind of go away from all the COVID restrictions, it looks like we're reverting to the old system, partly because the incentives to the participants are designed towards the old system, not the new system.
Yeah, I think that's a great point. One of the things that we're going to be looking at, I think, over the next few months are what are the learnings in terms of what works well through telehealth and virtual health, what maybe doesn't work as well or just needs some other type of intervention with it. I think to your point, there's a lot that we've got as an experiment over the last few months when it comes to telehealth. We have one more later left, and I want to make sure we leave plenty of time for our Q&A so that we can answer the questions that are on your mind as the audience. So the way we're going to do this one is I'll just frame it out, and then we're just going to do it as speed dating with our panel so everyone can just give a comment about it. That way we leave plenty of time for Q&A. The concept of neural networks, a lot of what's talked about when it comes to employee benefits and incentives is really around affecting utilization. That's kind of been the story for the last decade or more, that when employees have more cost sharing, that it controls utilization. But then of course that gives us that age-old question of, are we reducing utilization that was needed? Therefore we're actually making things worse, or do we reduce utilization that wasn't needed and therefore we took waste out of the system? And often that's very hard to figure out. Narrow networks are different because that's in some ways going after the actual price of healthcare And one of the things that we saw from our consumer survey, which was new, is their openness to the concept of neural networks, with over a third of consumers that have employer-based insurance saying they would select a plan with a limited network of doctors and hospitals to avoid a higher premium. And so that's kind of the essence. Are you willing as a consumer to have fewer choices, but maybe have that help reduce your premium? So in our speed dating on this, Mike, I'll maybe let you start out with what's your thoughts on narrow networks?
I never do speed dating, Ben, but I'll try. So first, I think you need to pay attention to how major employers are doing this. They're not doing it the way the plans have traditionally done it. They are picking partners, truly partners. They're starting with the quality agenda, but they're not limiting it to the clinical quality agenda. They're looking at the customer experience, the member experience. And with that, they're getting very high satisfaction. In fact, 32BJ, I mentioned earlier, mentioned that they were getting 100% a net promoter score on their, I won't call it narrow network. Think of it more of center of excellence or their advanced primary care, whatever that is. You know, we are seeing this as a key trend. Why? It's what you said before. We've run out of runway on cost sharing. In fact, we went well beyond where the plane can fly. And the way we're going to rebuild this system and make it affordable is to actually start picking our partners and working with them to provide a better experience, a better clinical outcome, and do so at a fair price.
Serena, any comments on narrow networks?
You know, I think it's all about like the value that you demonstrate. Like, do you know me? Like, whatever network you give to folks, why they don't want to leave their providers is because they have some relationship of them knowing. So do you know me? So then how well do you know me? And then do you take that information and then personalize the care for me when I need it? And so if you choose the providers that can actually deliver on that, which is Mike to your customer, it's really the experience of not only the patients, but their caregivers. And I think you can demonstrate that connection point, then I think you can make it work. But it's not necessarily about the model, it's about how you actually deliver the model.
Chris, final word on neural networks?
So, you know, I'm the radical irritant in this system, right? I'm the innovator that's trying to do new things. And as I listen to narrow network sort of discussions, I'm asking myself the question, how does it accommodate or incentivize new and innovative ways of practicing medicine? Because, for example, Ochsner Clinic signed a deal to partner with Roman to provide the Roman telemedicine services to members of their network. I mean, who would have thought that a large health system would partner with a retail telemedicine solution that generally provides, you know, cash pay for generic drugs? But they're thinking very innovatively about how do we expand our network beyond our traditional geographic boundaries and adopt innovative new digital delivery systems. Okay, so that's where I get concerned oftentimes with this narrow network sort of discussion is it sounds like it's going to be so narrow that people like us that are trying to innovate aren't invited in. And so how do we get us at the table in these narrow network discussions to really try to innovate the system?
Yeah. Well, I think that's a great way to wrap up the narrow network issue, which we think will be ultimately a deflator of trend in 2021. Let's turn to the questions. And it's interesting, we've been talking a lot about telehealth, and here at the top, I'm seeing already several questions about telehealth. I'm actually going to kind of combine two of them together and throw them out to our panel. So regarding reimbursement rates for telehealth, the issue is that largely as a result of the CARES Act, cost sharing has been waived for health plan members, so the plan sponsors are absorbing those costs. And the question is it premature to draw conclusions on fair payments for these services at this point in time? So a question around what is the fair payment for telehealth? And I'll just add in, because there was another question that I think connects to that, is how are we measuring outcomes in our, around telehealth? And those, I think, combine very well. What's the right payment, and how maybe should we be measuring outcomes differently? Who wants to make a few comments about that?
Sounds like a Serena thing to me.
Serena, you want to start us off?
Yeah, I was thinking about this and reading a lot about it. And as a company, there's been so many, if you look at, like, for example, the AHIP site, so many relaxation, I would say, about what we're paying for, et cetera. And honestly, for a provider, we need some semblance from our payers to kind of navigate through what's going to settle in, because it is kind of hard to navigate to really understand, is the payment going to be equal, or is it going to be less? And then it's not even just for the visit, because you have to think about costs, like from a telehealth visit, do you generate different types of imaging, et cetera? So the utilization of services outside of the visit, does that factor into the costs? So I would say from a reimbursement, I feel like it's still up in the air right now. I don't know if Mike, you had a thought on that.
I'm like jumping out of my chair. I got thoughts.
Yeah.
So, the first thought I have is, a lot of time when we frame this, we frame it in a fee-for-service world, right? And we say, well, it doesn't seem like we should have to pay as much for a phone call or for a televisit as we do if they have to go to the office, and all the overhead of the office and all that stuff. And that's kind of the way the thing is. I think what people who are a little bit more forward thinking are saying is, we're just paying wrong, period, right? Primary care should be more prepaid, should be more population based. Let them decide which thing. And then, Chris, to your point, if they're given the opportunity to decide, they're going to use the more efficient method, because they'll be incented to go there. And if we're talking about episodic care, episodes of care, bundled payments, let the providers take control of this, and let the consulting world, the PwCs of the world, advise them how to optimize the payments when we get there. The other thing you asked about was outcomes, and I'm going to just put a big plug in for Chris's world, which is, I think these technologies are way ahead in being systematic in collecting data on outcomes, and particularly on mental health, for example. They systematically do a measurement on the beginning and a remeasure on the back end, and they're collecting data, and they're getting it through the patient as part of that process. And frankly, providers themselves are not as disciplined as technology can be. And so I think we should welcome the fact that technology is finally entering the realm of healthcare, other than in big imaging machines, and so I do think, I am bullish on this, but I think we have to stop looking at it through the old paradigm. Let's think about the whole system and how to build the system we really want.
Mike's point, the Mayo study I referenced earlier in the discussion, they found that 25% of all telemedicine visits were for one thing: renewing a prescription. Mm-hmm. And physicians only really require you to come into the office to renew a prescription so they can get paid. And when you move that out of the equation, most physicians agree most of the time you don't need to come into the office to get a prescription renewed. Okay, so that's just one simple example of an efficiency that you can have with telemedicine that provides value to everyone in the system. Why clog up your waiting room when it takes me 2 months to get an appointment for a primary care doctor, and a quarter of those people are in there to get a prescription renewed? Get those people out of there. Renew the prescription another way. Let me in there so I can have my appointment in 1 month instead of 2 months.
Yeah, we had a question about any experience with e-care, so discussions with providers that are just via text and email, that physicians are often not really reimbursed for. I think it goes back to something I think, Mike, you mentioned, a lot of people don't have access to necessarily like video and the bandwidth for video. It kind of connects to what you're saying, Chris, and Serena, in terms of value of, how do we pay for some of this activity that may not be a formal, if you will, video visit, but there's a lot of value there with that back and forth and that connectivity with a physician by email or text. that's the modern way of
Yeah.
communication. What should we be doing in order to make that more a formal part of our health system?
Yeah, Ben, I mean, I think it goes back to, Mike, what you were saying about taking risk on a population. I mean, really, our model is that you essentially pay some sum, right? And you're saying, look, you're the expert. So whatever you have to do, whatever channel, whatever method, if it is texting sometimes, if it is emailing, it's this multimodal way of actually connecting with you, that is actually the best way to allow the provider leave the, I would say, leave the care to our clinicians. And I say that is actually the key in terms of, there's going to be multiple ways. I mean, all of you know, oftentimes you're going to need to email or text, and that's a part of, I'm now a Kaiser member. I've been for the physicians, they don't get paid on that, but they have to clear their inbox every night, and they're not texting, but they are emailing, 24-hour turnaround. I mean, that's one example, right?
No, that's a great example, and we had one more I want to bring up. I know we've only got a couple of minutes left here, and this person is asking specifically around any recommendations on how you encourage members or patients to get their annual physical exam done. But I thought maybe if you all could take that same question, let's take it up a level higher, just to how do we incentivize people? Because, by the way, each of us has said something about incentives during this discussion. So how do we incentivize people to do things like stay healthy, their annual exams, stay more connected? So let's use that maybe as our closing thought for our panel. Mike, do you want to maybe kick us off on incentives?
Well, I think we're in a period where we have gone from a zealousness about overutilization to a very strong concern about underutilization of high value care. And I don't know that everything in an annual physical is high value care, but we know immunizations are a critical thing. We know that cancers are being caught later. That is not a good out. It's not either it's not cheaper, and a lot more people are going to die as a result of that. We know people are not going to the ER because of strokes.
Yeah.
These are very serious things about high value care where people are finding not just financial barriers, which has been a concern and one that I think employers have contributed to, but also, just fear concerns. And I think we need to double down on education on high value care and what people have to do. Do we need incentives? Maybe. I think more than anything, you're not going to buy people to get around the COVID virus.
Yeah.
Not the reason they're going to go to the doctor. We have to make the case why you need to do this. We have never lived in our lifetime in a period where the majority of people have not been immunized. We have to take this very seriously, and we have to get people to get necessary care.
That's an excellent point. Chris, I know we're getting close here, so 15 seconds on incentives.
I think the biggest problem behind incentives is actually people's beliefs, right? So if you don't believe that some sort of therapy is going to work, or some sort of intervention, or that your professional can help, or that you can change your lifestyle to change your health outcomes, it doesn't almost matter how much I pay you, you're not going to do it. So I think there's a step before we think about incentives, and that is how do we help people understand and believe that the things that they need to do are good for them, and then we can reward them to do that, and they'll do it.
Serena, last word.
And how you do that is the trust. And we always talk about being that first call for the patients. And how would you be their first call? Is because you actually created a relationship with them, about knowing them and caring about your patients. So when they do need you, you're there for them, and they'll actually heed some of the advice that you have.
Well, we started out with the lens of looking at this world through employers and what they're going to be spending, but we quickly got into how care is delivered, the incentives around it, new innovations and drugs. So I think behind the numbers, we've got the full report out there available on our website, pwc.com/HRI. And would love for you all to, if you're listening, to take a read at the full thing and dig into some of the data that we have on each of these issues. I would like to thank our panel, Mike, Serena, Chris, for being just so open and available to talk about these really important issues. And I'll turn it back over.
Thank you, Ben, and thank you to all of our panelists. If you'd like to continue the conversation, please join us on Twitter. And now, please welcome Danielle O'Neill, joining us from Team Zoom Canine Entertainment. Her expertly trained border collies will be performing some of their tricks from their dog show.
Thank you, Health. Well, my name is Danielle, and me alongside my beautiful dogs are Team Zoom Canine Entertainment. And I'm so happy to be with you here today. A couple of things that you're going to see here today is you're going to see the sport of canine frisbee. And that's where the dog is going to do some really cool tricks, fly through the air, and even vault off my body just to catch this little piece of plastic. You're also going to see a dog who's actually deaf, who does a dog dancing routine, stands on my feet, and even jumps rope. Does handstands and even a somersault. She's quite the athletic little girl. We also have the Michael Jordan of basketball, our dogs with us here today. We have a dog named Nixie who loves to play basketball. And we're going to end off with a pairs routine of jump rope and frisbee. Now, I know this is a little bit different due to COVID, so we're used to having a big crowd cheering our dogs on because all of our dogs do work off positive reinforcement. That means we use toys, treats, and of course lots of love and praise to let them know what we're doing, and what they're doing is what we like. But because you can't be here, we would love to see all of your comments and all of your praise on Facebook. Don't worry, I'll sit down and cuddle on the couch and read every single comment to them just for you. All right, guys, we're going to get started with our first very exciting dog. He is a 2-year-old Australian Coolie all the way from Canada. Let's put a big round of applause for Icon. Come on, big man. Good boy. Let's spin this way. Good boy, ready? Woo! Good shot. Good boys. Woo! One more. Very nice. Good boys. Jump. Big catch there. Oh, nice try. Woo! Good boy. There it is. Woo! Big catch. Very nice. Woo! Good boys. Very nice. Now, as you can tell, he's quite the athletic guy. We're going to see if he can do a backflip for me. Come on. Full backflip. Nice. One more. Good boy. Oh, nice try. Good man. Woo! Let's give a big round of applause for Icon, everybody. Good job, bud. Woo! Now you are going to see me stepping off of the frame. I do have a couple of my friends helping me out wrangle some of these dogs, but just like with you at home and COVID, we keep 6 feet apart. So it does take us just a little bit of time. Now our next dog, woo, that one's quite crazy. Our next dog is quite an exciting little thing. She is a 6-year-old deaf, we think, border collie. She was rescued in Indiana in the middle of November when she was just 16 weeks old. Of course, she was cold, she was scared, and they had no idea that she was deaf. Now, she was born deaf, so she knows no different. Has not stopped her from doing crazy, awesome things. Whew. She has traveled from one side of this country to the other. She's even a Pure Incredible Dog Challenge Frisbee Dog winner that she won all the way in San Diego, California. Nowadays, she just loves to dog dance. And just because she can't hear you folks, doesn't mean I don't want you to give her a big round of applause. Here's Vibe, everybody. Hi, sweetie. Now, she does like to start off doing jump rope. And just like every woman, she's very patient.
Somebody save your soul, 'cause you've been sinning in the city. I know too many troubles, all these lovers got you.
Very good job, sweetie. Now she's going to show off some of her tricks. Make sure she's got a cookie because she knows she's doing right. Woo! Let's give it a look. Good girls. Very nice. Woo! Go. There you go. Stay up there, sweetie. All the way around. And we're going to go from our bag all the way up dead. All the way, still easy. Good job. Good girls. Woo! Good girl. That was a tough one. Good girl. No, I don't want that one. There we go. Nope, don't be lazy. Good girls. Now her two hardest tricks. She is quite the little gymnast. She can do a handstand. Whoops, wrong way, honey. There we go. And even the most difficult trick, a somersault. Come on, Teddy. There she goes. We'll go with both of those one more time. A handstand. Good job. And her somersault. Good. Go try it a little bit better, sweetie. There we go. Very nice job. Let's give Vibe a big round of applause. Good job, sweetie. All right, next on our list is Nixie. Now, Nixie is one lab. Everyone always asks us, is there a lab on your team? Just 1 second, guys, sorry. There we go. Woo. Everyone always asks if there's a lab on the team. And so I was like, you know what? No. Maybe one day, and I started looking for rescuing a lab, and I happened to find one. Now, she had a little bit too much energy for her owner, like many dogs that we own. We are strong believers in adoption. We thought half and half. And our little Nixie girl is just a highlight of my life. She loves to dock dive. She loves to bark, just like your dog at home, I'm sure. And of course, she loves to chew up cardboard, paper, and retrieve things. Let's put a big round of applause for Nixie, everybody. Come here, Nix. Hi, sweet girl. Now, this is Nixie's first year. She is a rookie to Team Zoom. So we want to make sure that she has lots of fun right when she's here and lots of cookies. So what we're going to do is we're going to work on her retrieval. Is it? So what she's going to do, she's going to take her basketball. I'm going to toss it to her, and she's going to come dunk it right in this basket. All right, Nix, what do you think, honey? Good girl. Come here, Nix. Let's dunk it, sweetie. Dunk it. Very nice job. We're going to do that one again. Now, I've only had Nixie for about, 6 months. Nixie right here. So she's still learning. No, touch up. Up, Nixie, come. No, you gotta dunk it. Nixie. Dunk it. Very good job. Like I said, I've only had her for about 6 months. So she's just now learning, and she's about 3 years old. There we go. Good job. All right, we're going to do one more, Nixie. Very good. Up you go. Oh, try again, Nix. Up. Very nice job. Whoopsie. Now, not only is Nixie quite the basketball player, but she is learning how to do cute little pirouettes. Good girl. Let's show off again. Oops. You took my watch off. Up you go. Come on, sweetie. Settle down. There we go. Come here, Nix. Let's give a big round. Nixie. Did you drop it? Come on, Nix. Let's give a big round of applause for Nixie. Nice job, sweetie. All right. Whoop, there I am. Now, we have definitely saved our two best dogs for last. This last skit is going to start off being a two-dog skit. We're going to bring out AWOL and Legend, and what's going to happen is, first off, we're going to do some jump rope, because as you saw before, Vibe was quite the jump roper. Now, Vibe's 6. Legend is only 4. And not to be outshone by her older sister, Legend said, you know what, I'm not only going to jump rope, I'm going to jump rope in pairs. So she hired her brother AWOL to help her out in jumping rope. So what we're going to do is we're going to go ahead and bring AWOL out here. Now, AWOL is a Dutch Shepherd, and so he's just like your military and police dogs. And what he's going to do is he's going to hold, thank you so much, John. He is going to hold the jump rope for Legend. Come here, honey. Come here, honey. Up. Sit. Very good job, bud. Can someone actually go over to that phone right there and just choose the next song and hit play? Now, Legend is a 4-year-old Border Collie. She is a tri-Border Collie. Here, honey. And she loves to jump rope and play Frisbee. Let's give a big round of applause for Legend, everybody. Stay. Legend here. You stay. Lie down. Legend. Good job. Legend. Lie down. That's the fun part about technology, especially with things. It only works when it wants to. Sit. Come here, Legend. Stay. Legend. I don't want to play Frisbee right now, honey. Come here. Lie down. You stay. You can go ahead and hit play. Thank you. The next song, just hit next. Right in. Hold. Drop it. Hold. Stay. You can go ahead and turn it up too if you want. Legend, come here. Jump. 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 Over there, honey. Oh, careful. Hold on. Jump. Jump. One more. Jump. Very good. Nice job, Legend. Very good job, AWOL. Let's give our AWOL a big round of applause. You want to call him, John? Thank you. There we go. Now I'm going to go ahead and clear the field for Legend. She needs quite a bit of room. Can you go ahead and turn that up for me again? You can, on the soundboard is fine. Right underneath the speaker cord. All right. So like I said, this is Legend's favorite offense. All right, sweetie. Drop it. Now, if you go forwards, remember, you must be able to go backwards. Even standing still. Woo! Ready, honey? Big catch there. Down. Good job, down. Nice job. Woo! Nice job, John. Good girls. Very nice. Come here. Bigger there, wait. Nice job. Woo! Good girl. That's okay. Good catch. Good catch there. We're going to do a couple of our new tricks. Drop it, honey. Just like everyone, we like to train in the off season, just like regular athletes. Can I have that? Thank you. Okay. Good catch. Now this one is going to be a catch behind my back. Woo! Good air there. Now this one is one of the most complicated vaults. This is called a reverse. She's going to bounce off my hip, hopefully invert, and then catch. Stay. Big air there. Wait. Woo! Drop. Good job, sweetie. Wait. Up. Stay. Good girls. Drop. Good job. Good job. One more. Woo! Let's give Legend a big round of applause, everybody. Let's give all the dogs of Team Zoom a big round of applause. Once again, my name's Danielle, and me alongside my beautiful dogs are Team Zoom Parent Entertainment. We would like to thank Health once again for bringing us out. We absolutely love performing, no matter where we are, webinar or in person. We'd love to see all your comments on our Facebook page, Team Zoom Parent Entertainment. Thank you very much, folks, and have a great day and stay safe.
Thank you everyone for joining us today. We hope you have a great rest of your day.